Welcome to Discover Midwives, the podcast where we explore the art, science, and impact of midwifery. I'm Jessica Brumley, and each episode we'll uncover the stories, the history, and the expertise of midwives. This is your space to learn, connect, and celebrate the power of midwifery. Let's discover midwives together. All right, welcome to Discover Midwives. Today, I am thrilled to have with us Alison Shorten. She is a distinguished researcher and innovative educator in nursing and midwifery, with a career spanning over 35 years. Alison's research is focused on improving pregnancy and childbirth outcomes through shared decision-making and implementing models of midwifery care. Her research has contributed to clinical guidelines and evidence-based pregnancy care internationally. She trained and practiced as a midwife in Australia and is now a senior associate dean in the University of Alabama School of Nursing. Welcome, Alison. Thank you for joining us today.
Thank you. And I will say University of Alabama at Birmingham.
At Birmingham. Fantastic. I love to start with a little bit of a story. In our first episode, I shared my own midwifery origin story. I would love to hear, how did you find midwifery, or did midwifery find you?
I think it's a bit of both, really. If I think back to my first year as a student nurse in 1985, aging myself there, but I witnessed birth for the first time. I just finished a rotation in gerontology, which is at the other end of the end of our lifespan, and switched to maternity care, and was absolutely amazed by the difference that midwives made in the care of mothers and their families, and the role that education played. It was a really important element of care, and the relatively short period of time that mothers were in the hospital setting, the amount of education that took place and support, and the decision-making that took place, the fact that midwives were using their knowledge, and that the providers around them trusted them in making decisions, and there was a good relationship between them. And so that was a really exciting thing for me to observe, and was quite different to other areas of healthcare that I had, been observing as a very young student nurse. So once I graduated and became a registered nurse, there was a requirement that you needed to practice for 2 years as an RN before you could enter into a midwifery program. That was in my location. I was in a place called Wollongong in Australia. And so I worked for 2 years, rotations in a hospital, in a local hospital, in different places, emergency rooms and medical surgical. And I spent a year as a surgical nurse, actually, until I was permitted to apply to become a midwife. And that was a turning point for my career. And I have been immersed in midwifery ever since. So I think it's 35 years this year. And it was a wonderful program to be in. It was very focused on midwifery models of care, and I was very fortunate to work in a setting that was very midwifery-led, and that made a difference to the way I see midwifery care as well, and the sort of models of care that can make a difference to outcomes and promoting physiological birth. And the midwives I worked with were very much about promoting physiological birth. So that influenced so many things along the way, and certainly into the research and the areas that I'm working in.
I love that. One of the reasons why I love working where I do is because I get to influence future healthcare providers, physicians, nurses, midwives, and to be able to be part of those foundational years is just so powerful. And I know that I'm helping to train my future colleagues and collaborators, and so it's really important work. at some point along the way, you became a midwife scientist.
Yeah.
And you have focused on evidence-based practice and empowered decision making, which I heard you mention already as something that you noticed how the midwives were helping to support that decision making, even when you were in nursing school. Can you tell our listeners how you came to focus on these topics?
Yes, I think it was in the 1990s then, and I was very fortunate to work with a midwife, Georgie Stamp, in Australia, and she introduced me to the book Effective Care in Pregnancy and Childbirth, which I think there were two very large volumes published in about 1989, and then that book developed into a guide for effective care in pregnancy and childbirth. And what really surprised me was in the back of the book, there were some lists of things that were, care that we know is effective, care that we know is beneficial, care that we're not sure about because perhaps the evidence isn't available, and care that we know is harmful. And that was remarkable to me. And on that list were things that we may still have been seeing in maternity units, and there were still things that were occurring that we could see from evidence that were not beneficial, and in fact, some could be potentially harmful. So that was really important. And I also was able to meet at least one of those authors because, Georgie had been colleagues with them, and the Cochrane work was underway, although in the days, we're talking 1990s here. And so I became very passionate about changing the way that we approached care and moving away from what we were seeing as ritual, routine, and rough guess. And a colleague of mine, Margaret Wallace, she was also a midwife, and we were teaching together at the University of Wollongong, and we wrote 3 articles on evidence-based nursing. I believe they were the first ones to be written, certainly in Australia, and we called them Evidence-Based Practice, We Don't Have a Choice, Evidence-Based Practice, The Future is Clear, and Evidence-Based Practice When Quality Counts. And they were just short papers, very accessible to clinicians, and we started running some workshops around what evidence-based practice actually meant and how could we do that? How could we introduce that? And about the same time, I'd also noticed that in our midwifery data collection, we had national data collection. We could see that there were differences in outcomes in terms of birth outcomes, mode of birth in particular. And those differences were occurring in different hospitals because you could see which hospitals were listed. And some of them were private, some of them were public. They had different case mix. And so we started to really dig deep into determinants of birth outcomes. And, we found that it wasn't necessarily the things you would see as medical indication driving a lot of these variations in practice patterns. So we started to explore things like determinants of perineal outcomes. So we did some work on that, and we were having a look at C-section rates and things. And then about the same time, there was concern raised about variations in C-section rates, and the VBAC rates were varying and also reducing. And about the same time, the New England Journal of Medicine had published an article on VBAC, and that was quite influential in McMahon and others, and getting people to look at VBAC. And so these sort of things were culminating at the same time. And one of the things that was really important to me, and as a PhD student, I started to delve into the fact that our women and families were not aware of the the research findings that influence the outcomes for their births and their pregnancies. So I set about figuring out how to provide and translate evidence-based information and get that into the hands of our patients so that they could make decisions that were best for them. So it was about informed decision-making, translating evidence from practice. So you've got your providers that need the evidence, but our patients and their families need the evidence and to be able to use that in an effective way to make decisions that are going to be best for them, because ultimately those decisions will influence their health for the rest of their lives and the health of their children. So that's how I became a midwifery scientist and started to focus on shared decision making. Originally, we talked about informed decision making. People like Annette O'Connor had been developing the decision support framework in Ottawa. I had permission to use that framework to adapt to the decision around VBAC or repeat C-section. And we developed a decision aid, trialed it in a randomized controlled trial, and we found that it was effective in improving knowledge, reducing decisional conflict, and helping our patients get to a decision that was best for them. But of course, there were a lot of nuances about that. But essentially, it's all about wanting our patients to be well informed and to be able to take that information and use it in a way that suits them, because we know that our patients have different values, preferences, needs, experiences, and all of the things that will influence their decisions. And we need to help them to get to the decisions that are going to give them what they're seeking.
I imagine, I know a lot has changed since the 90s to now, where information before was actually quite difficult to access. And now it seems like what's difficult is determining the quality of the information, because it is actually too much information, right? And oftentimes I tell people, I'm here to help you filter through, right, that that information. So I think this is just like one example of what can make decisions more or less difficult to make. What can you tell us about, like, what helps, what makes decisions more or less difficult to make?
I think the VBAC versus repeat cesarean, that one is a really difficult decision for many patients and families to make, because there's the factors associated with the first birth. So there's all these things that are really informing that decision that aren't obvious to us initially. So I think that it's difficult sometimes because patients need support in identifying those things for them too. So we can help them to do that by helping them identify the factors that are important to them, and then helping them to ask the questions that are going to help them come to the decision that they are going to make ultimately. So you've got the patient factors and the medical backdrop too. What happened in the previous birth, what was satisfying, what wasn't satisfying, what do you want to repeat, what do you not want to repeat, all of those things. So there's those patient-driven factors, and family and friends will influence those as well. So there's a lot of those elements in decisions, and that makes it difficult. The other thing is that we don't have certainty in outcomes, because there are so many things that will influence a birth outcome. So, for example, if someone's approaching a VBAC, we can say that the research tells us that these things are more likely, these things are less likely. So we've got the research that tells us elements that will help make decisions, but there's no certainty. And decision making under conditions of uncertainty is really challenging. And for some patients, they'll see greater risk than others. So, for example, if you present information about the likelihood of a particular outcome, some patients will be more fearful of that than others. Or they'll say, that's got to happen to me. I mean, they might be really risk averse in that way. They can see that 1 in 100 is really concerning to them, whereas others will go, oh, well, that's 1 in 100. So there's the different ways that we approach what we could term risk, or the way we could approach the likelihood of a particular outcome. And when there's uncertainty, we need to be supported in helping to figure out where we're feeling about that. So it's not straightforward, and that only comes out of discussion. And that's where the shared decision-making piece is really important, because there needs to be early discussion, particularly if it's a mode of birth decision, early discussion and lots of thought. Relationship-based care is really important for that, because it's a building of a relationship. Again, what's challenging about that is within the way our healthcare is structured, often we'll have different people making, having those discussions and making a decision at one point and carrying out a decision at another. So that's challenging as well. So there are many elements within the context of making decisions in pregnancy or making decisions about birth, that some we can control and other things we can't.
I often feel like I'm a detective when I am helping someone to navigate a decision around vaginal birth after cesarean. I'm getting the operative report, and I'm getting the summaries of their past hospitalization, and sometimes the indication on the operative report. I look and I dig, and actually they didn't even meet the criteria for that particular indication, and so, there's that level of digging, but then it's also digging into what that person's experience was, and, how did they feel about that experience, and what work they've done to kind of, get over some of that trauma before coming into this pregnancy, thoughts about future pregnancies. It's just so many layers of conversation that need to happen. And so when I came across the resources on Partner to Decide, I was just thrilled, because they're so well done, and really I can't wait to get to use them. So I wondered if maybe you can just share a bit about what these resources are.
Absolutely. And I'm going to credit Anne Peralta here, because she is the originator of the Partner to Decide website and the induction of labour tool there. And we worked together with Carrie Radoff on the VBAC tool, which is an adaptation from my Birth Choices decision aid. So the thing about the Partner to Decide decision aids is that they are very concise. They're well crafted so that they're easy to understand, translated into multiple languages, and they take someone through a pathway of decision making, having already anticipated some of the questions that will come up, and helping patients identify the values, the things that the clarification, values clarification, the things that are important, the other questions that they have. So all of this is done within a very concise framework. And when I say it, I've adapted the Birth Choices tool. That's a more lengthy tool. It's a booklet, and I had developed a website. But I love this format that Anne had developed, where the key elements of a decision aid are all there. We're describing what is it to have a VBAC? What is it to have a repeat C-section? What does the research tell us about the pros and cons of that in terms of the complications? What complications are possible? What are the quick facts in terms of what happens during a VBAC? What happens during a cesarean that is a repeat cesarean? And what happens if the labour doesn't progress? And so it's thinking about all of those things that are key elements that come up in research about decision-making around that decision point, and making it really easy to walk through. So these decision aids are really helping providers also walk patients through this. So it could be a tool that a patient can use themselves. So you could get it from the internet, go through it, show it to family, or, and to work through it. But these work best when patients and providers are working together through the tools. And it may be more than what, you may need to do that more than once too. It's not a one and done thing, because things do come up during pregnancy, things change. And so to have a tool that you could use early and again, at different time points, is going to be really valuable. And, ultimately, when a decision is made, there are elements to that. So if, for example, in this decision aid that is in Partner Decide, there's a really important page in that. I did print that out before we're talking to so I could just refer to it. But there are so many elements to it that patients can check boxes and sort of have something, a piece of paper even, or of course on an electronic device, and show a provider and say, these are the things that are on my mind. These are the other questions that I have. If we go down this path, this is what I'd like to happen if I go down this path. And it's documenting as well. It's having a document there that helps to guide final decision making and then translate that to what happens. So having that tangible tool that patients and providers can work on together is really valuable.
I do really love how it asks about the individual's values or
Yes.
preferences, how it has that space to list out the questions, and then also how it uses the evidence to present in a really digestible way each of the sort of decision points
Yep.
that one might experience. So well done, and open access, right? Meaning it's free. You can just find it on the website and just download it, available in so many languages. So I thought that was, amazing as well. I just really loved everything about it. And as you mentioned, it includes decision aids on Partner to Decide. There's a decision aid on induction of labor and vaginal birth after cesarean. And I have to say, as a midwife practicing in a large referral center hospital, induction of labor has become increasingly common throughout my career. And in the past few years, I find that it is requested and recommended often without the thorough consideration that it really deserves. What do you think surprises people about getting induced?
I think what I've observed over time is that the surprises about not really knowing whether it will work in a particular way. So an induction can be unpredictable, it can happen quickly, it can take a bit, and sometimes it doesn't work effectively. So I think there's the time frame for some of our patients is unpredictable. So I think that comes as a surprise. It's like we book a date, we've got to have the induction, everything, and not everything will proceed necessarily in a way that's expected. Sometimes schedules can get moved around too. So someone, depending on the hospital, someone might be booked for an induction, but whatever is going on, maybe things need to change. And that can be really emotionally difficult, because if you're making plans, you're thinking about it, and we know that the psychology of labour is so important. And so entering into labour with uncertainty or changes that are unexpected can be more difficult. Sometimes it's the pain that is experienced too. And if someone has had a spontaneous labour and then an induction, the pain experienced can be different and more painful. And anticipating pain relief is sometimes a surprise. So there are those aspects of it. I'm not sure that there is widespread understanding of the cascade of intervention too, and the fact that an induction can lead to other things that are unexpected, and it might be an induction results in a different experience of pain. Someone wasn't anticipating that they couldn't move around as much, or weren't able to carry out a birth plan that they had in mind in relation to the labour. And then you have an epidural, and then you might have an increase in operative or instrumental birth, depending on the situation. So there are those unexpected outcomes as a result of having the induction. And so that's all being weighed up. And we know that from research, certain pathways take place. But I think that there is not widespread understanding of that. And that's where, again, the decision aid comes in, because all of those aspects are presented in terms of what is the likelihood of this? How might you experience it? What are the things that you can do to manage pain? What are the things that you can do to become more active? All of those elements are within the decision aid. So that's important.
I know a lot of my patients don't always want to be induced, and it's part of why they come for midwifery care. I also know many people in my community that have been recommended an induction and are fired from their provider because they are not consenting to their provider's recommendation. So if someone's been recommended an induction and they want to consider expectant management, AKA waiting for spontaneous labor, how can they use this tool to really begin a conversation with their healthcare provider?
That's a really good question, because the fact that the tool's widely available is really important. So you could print it out, take it to the consultation and say, I have this resource and I'm wondering, what does this mean for me? And let's look at, what are the benefits? What are the downsides? And actually use the tool. The important part about the tool is that it's based on good evidence. There are ACOG recommendations and other things within the tool. So that's something that's important to highlight. This is how this tool was made. These are the recommendations based on these really important guidelines. And so being able to have that conversation, I think the tool is very useful in helping a patient walk a provider through the questions that are coming up in regard to that recommendation. And it really does bring the point together to say that, well, for your situation, these are likely to be the benefits. This might be the downside, and to talk about that. And if the decision is, well, what would happen if I don't do anything? What would happen? What are you seeing as the likelihood of this complication if I decide not to do that? So it's really an important. I guess it's just a tool. It doesn't guarantee the outcome of a conversation. I think that's really important to know. It is a tool, and it just it helps empower patients with language and what questions to ask and how to hone in on the things that are worrying them the most about it, or the things that are helping to drive their thinking or their decision about it, and raising awareness of their provider that these are the things that are concerning. These are the things they need more information about. These are the things that are going to make a difference in whether this is a successful, if an induction is chosen, whether this is successful or not, or what other things need to occur if someone is using expectant management, and what's the plan. So it does get everyone on the same page, but it's introducing the topic. Sometimes it's hard to know where to start with a question. So having something to say, hey, I found this. Mm-hmm. And this is really interesting, and these are the questions that came up, and it can work in that way. No guarantees, of course, that it will happen first time round. So I think having some of those conversations earlier, if you've got a provider and you've got that continuity of carer or continuity of care in the model of care, you're able to think about these things earlier on and anticipate that for some induction is brought up, and here is the question I have about it. What are your thoughts on that? It might not be part of the conversation at that time in decisions, but it might help if that conversation is needed at a later time in the pregnancy. So it's using things a little bit earlier can be really beneficial compared to waiting until you've got in some ways it could be a more difficult conversation if there's a sense of urgency. And it's sort of really let's walk through this. Let's talk through this. But if you've already had some of that conversation earlier on, it might make it a little bit easier too. And these tools are useful for that.
It sounds like it can really help to strengthen the relationship through that conversation, right?
Yeah.
Having a guide to help you to have that conversation in a respectful way can help to lead to a stronger relationship between the care provider and the person seeking care.
I think you're absolutely right. And it's so important for our patients to know that we're listening to them and to know that we hear that they have questions. We hear that they have a perspective. We hear that there are things that are important to them. And so that is part of respectful care, to know that someone has heard you, rather than a one-way decision. It's a shared decision after all. And when you're making a shared decision, there are things that are going to be, as providers, might be things that are on our mind about it, that we're concerned about in past experience. There are things that will influence why we're recommending it. And so they're also part of the discussion. It's shared from that perspective, and the provider is going to support whatever decision is made. And that is so important in the VBAC and C-section decision making. When we look at the satisfaction with outcome and with birth, it's not singularly about the method of birth. It's about what aligns with expectations. And for some patients, the attempt of having a labour is the really important thing to them. And sometimes that doesn't result in a vaginal birth, but it's the being able to try that was important to that individual, and having support in that. And even though they might not have had the outcome of a vaginal birth, they're still satisfied with their experience because they had what was important to them. And having that conversation is really important, to know what it is that is going to improve the experience for the birth. It is about the experience too, because that's what's reflected upon later on too. Yes, mode of birth is really important. Mode of birth is important. It does influence health, and it influences other outcomes in the postnatal period and beyond. But the experience is also important. And we can have really positive cesarean experiences, and that's really important to be able to do, to have really positive cesarean experiences. But also, if somebody really wants a VBAC, being able to achieve that is important too, and feeling supported in that choice. So it's about being supported in the actual decision that is shared.
I love that. I often think that we need to pay more attention to patient experience as a valuable outcome. It's so often what you hear reflected in, is outcomes as in vaginal birth or cesarean, full-term birth or preterm birth, or hemorrhage or, physiologic blood loss. But, we don't just want people to survive birth, right? We want people to have these supported, empowered birth experiences, and not to leave a birth feeling traumatized. And it's rarely because of a catastrophic event that people feel traumatized, but rather because they feel rushed or coerced or unsupported in their decision making. And it sounds like these are tools that can help to not only improve outcomes, but improve the outcome of the patient experience. And the way that you've described its use, it can help support individuals who maybe have had a traumatic first C-section and are needing to make these decisions. Yeah. Um, I find that medical decision making for unexpected medical indications, such as a new diagnosis of gestational hypertension, can be incredibly difficult for anyone who desires to await spontaneous labor. Can you please share recommendations for our listeners on how to engage in shared decision making without a decision aid?
Well, there are many decision aids out there. So you've probably got a greater chance of getting a decision aid now. But if someone is in a position where either they don't have that on hand, they weren't aware of a decision aid, and they don't have a decision aid, and we know that the vast majority of patients are going to be in situations where they're facing making a decision about something without having prepared for that, because these things come up. And so it's about benefits. So what are the benefits? So what are the benefits about, regarding that? And to have this sort of way of asking questions. So what will be the benefit? What are the risks associated with that? What's your intuition too? You've got to say, what are you feeling about that? How does it make you feel? What are the alternatives? So are there other options? And then what happens if we do nothing? So if you're thinking about an induction, it's what are the benefits? What are the risks? What are the alternatives? How are you feeling about it? And what happens if we don't do it? And so that is actually, it was Anne that shares this, because she was thinking about from a patient perspective when she was developing the induction tool, and I've been talking with her about, well, what do you do if you don't have decision aids, or what approach do you recommend patients take in these situations, and what language should they use? And she said, well, the brain. And that's what it is.
Use your brain.
It's the brain. So benefits, risk, alternative, intuition, and nothing. And what happens if you do nothing? So I loved that as a guy. I thought that is a really easy way to remember, and that can be applied to any decision context, within healthcare, really. And if somebody is pressed to have to make a choice at that time, to be ready with that and ask those questions.
I love it. I often share that as a tool as well. So beautiful. What else would you like to share with our listeners today?
I think, from the perspective of providers, to work to share decisions, and that's sometimes challenging for providers as well, because there'll be things that are important to us that often drive the way we are having conversations with patients. And to take the time and know that if you take the time, you're going to make a difference in experience. So whether you're using tools or using your skill set, find out what is important to our patients, find out what are the things that are driving their thinking and their decisions, and using whatever tools you have, whether it's a decision aid or whether it's your conversational skills, relationship building, whatever it is, make sure that you're listening to what is important to your patients and families, and for patients to know that there are tools out there to help, and that it is a really important part of healthcare, and that it is okay to ask questions, because ultimately the decisions we make in pregnancy and birth and in healthcare generally affect us all for the rest of our lives. And so it's really important to value our experiences, but also listen to our providers. When it's a shared decision, it's a shared decision. So to have an open mind as to what might ultimately occur in birth, and to know that your providers care about you and care about the outcomes.
I love that. Thank you so much for joining us today. Yeah. As we wrap up, I want to leave you with this. You deserve care that listens to you, respects you, and includes you in every decision about your body, just as we discussed today. If something in today's episode has resonated with you, I encourage you to write it down. Talk about it with someone you trust and bring it with you to your next healthcare visit. Maybe you bring one of these decision aids with you. Information is powerful, but using it is where the change begins. If you found something in this episode helpful, you can follow us or subscribe wherever you listen to podcasts. Sharing this episode helps more people learn about their options and what respectful maternity care can look like. Thank you for spending time with us today. Take good care of yourself, and I'll see you back here next time. Discover Midwives was brought to you by the American College of Nurse Midwives. To find a midwife in your community, go to midwife.org.